water with a straw. I have a piston syringe. Hi. I'm ready for my close-up. No. A piston syringe with some water in it as well. Okay. This is simulated saline, but I'm going to use it in place of the lubricants because we can't use actual lubricant on these mannequins because it's water-based. What happens with water-based lubricant after a while? It gets gummy and sticky, and then it corrodes the inside. So we just use this in place of that. I have my size, which size is this? This is a 14 French, excuse me.
You said 6.
I thought it was a 16 is typical.
Oh, up close.
Now typically on here, it is, and it fairly is. Usually they'll have it written up here, the size, because this is where you're gonna be able to see everything, okay, for you to verify. This is the anti-siphoning one. We don't really do anything with this. We might put a cap on here to prevent these holes from like sticking up alongside if they get suctioned while suction is on in the stomach. Remember I talked to you guys about the intermittent versus continuous? Okay, so even with the intermittent, this could get up against the inside of the stomach and cause hickey type situation to happen on that tissue. And so this is to help prevent that so that it doesn't and stay up against that tissue, okay? But I have my towel and my gloves. Is there anything I'm missing? They said stethoscope, but did you ever see her use it?
No.
Your pen light.
Pen light. Who's got one? She used a stethoscope at the end?
To like listen, but to the heart. I don't know what else she was.
I'll let you know. Okay. So now we've got that. So one of the first things, what I don't have, I thought I did, tape.
Oh, you have to have one of those little basins.
It's good to have that in case, of course, you cause your patient to get nauseous. Yes.
That's not big enough. That basin.
Oh no, that little kidney basin? No.
That's for brushing teeth.
Yeah.
That's about it. And rinsing. But yeah, no, I usually get them the big bucket.
Do we thermal washes? That helps.
Oh yeah. See that? Alright, so what I'm going to do now is I'm going to create what's called a chevron. Okay? A chevron. You know, like
It's
the
a
gas
gas
station.
station?
Or, you know,
The pattern.
it's a pattern with the stripes when they meet together. Okay? It's called a chevron. And so I'm just going to tear this in half lengthwise like this. Not all the way down. Okay? And I'm going to just take these ends and bend or fold them over like this.
Can you show the camera? And you're leaving that little space to kind of tag it?
For later on when we go to remove this, now these will be easy to find and peel off.
So you don't have to dig with your fingernails in their skin.
And they're like, okay. So I have 2 pieces of tape here and I'll show you why in a little bit.
Are they both the same?
About the same length.
No, I mean, like, did you do both tapes the same, or just one regular and one?
One regular, one chevron.
Oh, okay, got it.
No, and actually we don't use betadine anymore anyway because there's too many people that are allergic to it. So we actually instead will put a skin protectant on the nose, and it has a sticky property to it if you let it dry a little bit to help this adhere to the nose a little bit better. And if your patient is really diaphoretic and sweaty, which sometimes people who are nauseous are, if you take some alcohol and clean the nose first, it sticks a lot better. Because it gets that oil and everything off of their nose. Alright, so what I'm going to do now, is this a sterile procedure?
No.
No. I also have my suction ready in case. Okay. So, well, yes and no. Yes and no. Depends on how, when I say compliant, your patient's ability to follow directions is. Okay. So he is actually just a little bit too low. Careful. I'm going to raise the bed up a little bit. Because again, I want to be working at a comfortable working height. I don't want to have to be bending over. I want to be able to stand up while I'm doing it. Stand up straight while I'm doing this. All right, so she looked up the nose. What for?
Make sure
Any obstruction, polyps, any type of things that might, cause an issue. Now he has a beautiful septum, oddly enough. Okay, nice and clear. There's no obstructions or anything like that. And actually, yeah, you can see the back of his throat this way if you really wanted to. Okay. But now this is where it gets a little bit difficult. Can I have you hold its forehead back? Because I can't do this with one. I can kind of see, but not really, the back of his throat. Okay, but as long as you're able to, on an actual patient, you'll be able to see the uvula and all that fun stuff. But on him, it's a little difficult because he's made of rubber. Okay, so I didn't see any obstructions or anything. Okay, what are my points to measure?
from mouth to ear, from ear to
From the mouth?
From the nose. Tip
From
of
the
the
nose
nose.
Tip
to
of
the
the nose.
ear.
Because I'm not putting it in the mouth.
Yeah, I just remember it was here.
It's okay. So I usually take the tip and line it up with the tip of the nose. So tip to tip, roughly to the external opening of the ear, right just past the tragus. And then I come down and I'm going to expose his chest here, but I'm going to come all the way down to where his xiphoid process is, because the stomach is right over here, just behind that, okay? So I can mark that. If I don't have these nice little hashtags on here, I can either mark it with a piece of tape or just know I need to go to 45, okay? If I was to take a piece of tape and do it, I'd just write that. Or you go a little bit further just to make sure you're all the way past in the stomach. Because right now it's just the tip. We want all of these holes here in that stomach to do the job that they're supposed to do.
And you said, like, if you go too far, it'll coil up and then...
Well, no, it typically will coil up here in the back of the throat.
Okay. So how do you, like, what happens if you would go too far? Is that
You can go
possible?
past the stomach.
And that can cause damage?
It can. There's certain tubes that we utilize, because these are actually kind of going out of style as far as feeding through. Typically these are for gastric decompression, so if someone's constantly throwing up and we're worried about their airway becoming compromised, okay? Because constant vomiting causes heart issues too.
Yeah.
Okay. So with those, we'll put this down to get to suction stuff out of their stomach so they're not throwing it up. Okay. We have another tube that's similar to this, that it's called either a Dobhoff tube or a post-pyloric tube. It's a more of a vinyl, softer plastic, if you will. Kind of more like the glove material here, how it's softer. It's much more comfortable for the patient, but the tip goes past the stomach into the duodenum. That's why it's post-pyloric. And then you feed through that instead. Your eyes just got huge.
Is that one more long term then?
It can be. It's usually a precursor to getting a PEG tube, which is the tube that goes through the abdominal wall directly into the stomach for feeding. Okay. So I'm gonna have, if my patient's unconscious, like the ones I'm used to working with, I'm gonna have my hand back here, or I can have another person have their hand, but we want to tilt the head down. Okay, and then what that's going to do is it's going to encourage this to go back to the back of the throat and down and slide in, hopefully, to the esophagus. Okay, because you have in this little area, okay, and it's even smaller, so it's not going all the way back to this part of the neck. Okay, it's only about here. So you've got a very a finite space that you're working in, if you think about it, okay? Here is your trachea, okay? And then behind that is your esophagus. So more posterior, okay? So we want to encourage this to go as far back to the back of the throat as possible to ensure that it's going to go down into the esophagus and not the airway. That's also the purpose of having them swallow, because when they're swallowing, what's happening to their epiglottis?
It's closing.
It's closing over and protecting the airway, so this will encourage again to go into the stomach, and then those muscles can actually grab this and kind of help force it down the right way. Okay. If you're worried about comfort for your patient, you can curve this just a little bit. Or if you're having a really hard time, you might need to soak it in some ice water to stiffen up the plastic a little bit. But don't need to worry about that with the mannequins. Okay.
Why would you want to stiffen it and not soften it?
Sometimes like if it's continuously coiling in the back, you want it to stay a little bit more rigid so it goes in and not like hit something and go like this. So,
Are you gonna do it fast?
I'm gonna be doing it slow so I can explain it, but yeah. So,
He's
I've
biting down. He's like, nah.
oop, before I even start with that, in case he spits up a little bit, cover up his gown. This. And I will have, since, well, he's quadriplegic, so he can't use his arms. I'm gonna be my seconds on that. Okay. All right. I like to have my syringe at the ready. I'll show you why. Okay. So I'm going to lubricate up to at least the first 3 to 4 inches of this with some type of water-based lubricant, not petroleum. All right. All right, Mr. Smith, we're going to get you your NG tube now, okay? All right, so I've got his head tilted down. And when I say, I'm going to have you sip some water, okay? All right, so on 3. 1, 2, 3. Here we go. All right. Now I can kind of feel when it gets to the back of the throat, okay? And you want to kind of turn it towards the septum once you get that way, just to kind of help with getting it down. Okay. Go ahead and have him take a few sips while I'm advancing at the same time, having those muscles work. I don't think it's going to let me go any further than that. Okay. Should. Excuse me, Mr. Smith. You can, if you guys want to take a look, you can see it in the back of the throat there. When you put the push the tongue down. You see it?
Yeah.
I'm like bending his teeth, but most people you don't need to have them open up that much.
Take your word for it.
I'm sure. I'm just vertically challenged. Oh, is that on the right? Yep. Oh, yeah, that's it. That's good.
Okay. Not even the real thing.
I know.
All right. So I'm going to keep advancing and getting it all the way in there. Now, for the mannequins, they usually don't let us get all the way down here.
So when do you stop having them flex?
Once you get past the back of the throat and then smooth sailing, then you can have them relax.
Okay.
Okay. And if you want to have them continue to sip, have them help with that respect. In that respect, that's fine too. Okay. Now, we are not actually going to put tape on the mannequins, but what I like to do, once I've gotten this in, before I tape it, this is where you would want to have a little bit of air in your syringe and your stethoscope. Because you'll want to take your stethoscope and listen right around in this area where the stomach is supposed to be, and just give them a little bit of air, and you'll hear a okay? That does not confirm that you're in the stomach, but it does confirm that you're in the right area. Because if it's over here and you hear that whoosh, it's not in the right area. You've gone too far, okay? The only way that, there's 2 ways that we can, well, one at the bedside that we can confirm that we're at least in the stomach, which is how?
You aspirate some
Some gastric secretions, okay? Well, or secretions, I should say. We don't know that they're gastric until we test it with these guys, okay? And that's actually the most preferred method, because at least you know it's in the stomach at that point. Because if it's a basic solution that you can pull up, that's lung secretions typically. So then you're in the lungs.
That would be like the clear.
It wouldn't turn the acidic colors, yeah, that you're looking for. Okay.
So then you gotta like pull it out and redo it.
Yep. You can't put anything in it. You know what I mean?
Do you pull it out all the way?
And
That's
try again
fine.
later.
Later or like not right away?
Not right away. Give the patient a little time to relax. Right.
Oh, okay.
Now, if you're putting this
Take a
in
term
and
for
the
that this is
patient,
happening again.
if you're putting and advancing this and the patient is coughing, what do you think you need to do?
Take it out.
Take it out because you are in the lungs. Okay. So, or at least irritating their cough reflex. So you're definitely in the wrong area. Okay. So I've heard that. I've tested this. I still need to get what?
X-ray.
An X-ray to make sure. I'm going to tape it beforehand, so that way if it doesn't move between now and the time the X-ray gets up here. But I will need to get an X-ray to confirm that it's in the stomach.
Gotcha.
Okay. We've done clues to say, okay, we think it's in this area, we think it's in the stomach, but the only way to really confirm that is with the X-ray.
So once you get the X-ray, then you can pull the gastric secretion out?
No, you
Or-
do the secretion bedside to make sure you're in the
Oh.
stomach,
In the right
but then the
area.
X-ray
Yeah.
confirms it.
Gotcha. So it's like a second.
So would you only do the empty tube when you have like X-ray with you, just so that
Well, no,
you
I mean-
shot, or do you just leave it in there?
Leave it
then
in there
Let X-ray know,
And then they'll come up to take a picture.
Yeah, I see. Okay.
And nowadays, what's really nice is a lot of places, especially well in hospitals anyway, they have
Bedside X-rays.
digital X-ray machines. So you don't have to wait for them to go down to radiology, process it, look at the film, all the other stuff. They can pull it up on the cart.
But do you still have to
Look
wait
at
for
it
the radiologist to put it in there before you
And
can do
still,
the
it's
order?
okay. Well, and
Before
then you have
do
to,
the-
if it's not the physician that ordered it, that's the radiologist or whatnot, you still have to notify the primary physician that ordered the chest X-ray and the NG tube being placed, and let them know what the radiologist's findings were, and then they can tell you it's okay to start either feeding or suctioning or whatever. Okay. So what I'm going to do is I'm just going to put the tape on my finger like it's their nose. We don't put tape on the mannequins at all. Okay. So I've cleaned up my spot here, got everything nice and prepped. I'm going to take my solid piece of tape and put this across my patient's nose. Okay, and that's going to stick to that skin prep and make it, that cause it to be a little bit more sticky, and this will be sticky onto that. Then I can take my chevron and put it on that tape so that it's nice and strong now. Okay, and then I'm going to take one of these chevrons and wrap it around. Just one at a time. All right, you want to go first? Fine. Doesn't matter which. Okay, because I'm going to go around like this. And then the other one, I'm going to go in the opposite direction. I didn't make my chevrons long enough.
Do you ever go? You never go under the tube because that would pull it up, right?
Oh, I went under the tube.
No, I meant like under instead of over the top first.
Oh, up here?
Yeah, like if it's never mind.
Doesn't matter. Which way do
Does
you
Well,
it
you don't
matter
want to put. You don't want to tape down here.
Like if the tube is here, so instead of going this way and around, you always want to go top.
You can.
It doesn't matter.
You just want to make sure you're wrapping around
the tube. Okay.
Yep. And you never wrap directly over it's the same tape again. That's why it's in a spiral. Okay, because otherwise it could break. If you're taking the tape off, it could tear, and then you're really kind of SOL. Whereas at least with this, once I get around, I'm good because it's just sticking to this, not to itself. Okay. And that goes with everything. When you put bandages on lower extremities and stuff, you always do it in a nice little spiral. You never keep going around like this because then it can cause a tourniquet type of a situation. And now this will sit. Now, can my patient pull this out? Unfortunately, yes. Okay. With confused patients, we might have to put restraints on so they don't pull on things. But for the most part, patients, if they're compliant and stuff, they don't pull this out because it's making them feel better. It might be a little uncomfortable, but it's not as uncomfortable as constantly. So now, let's say they've come up, we've cleared through X-ray that it's in the right place. Take this off right now, okay? Imagine this is still taped. And we have medications that we need to put in here. Okay, of course, Medications, pills. There's certain pills that we can crush, which we'll get to in med administration. There's certain ones that we do not crush whatsoever. But we have different ways of giving medications. We have syrups, we have IVs, we have IM. We want to do our best, though, to use the patient's natural stomach juices and everything. We want to keep it moving, because once the GI system stops moving from like surgery or anything like that, it's very difficult to get it going again. And the patient develops what's called an ileus, which means their digestive system is not moving along. They're not passing gas, they're not digesting food, which means if they're not digesting food, they're not getting the nutrients that they need, okay? So we want to try and always use their stomach and things as much as possible. We don't want to have to feed somebody through an IV if we can avoid it. So what you should be doing before you access this, to make sure that, don't just load up your medications and give it. You do need to flush this. So remember SAS, okay? Oh, I haven't told you yet. I'm just saying, remember this.
Oh. I was like, oh no.
When we get to IVs, or when you guys get to IV medications and IV pushes, SAS is saline additive saline. So when you're accessing an IV, you flush with saline first to make sure that it's open and patent. Then you give the medication, and then you flush at the end with more saline to make sure all the medication's in the patient that was ordered. Okay.
I know with blood too. They
Do you guys do that?
Yeah, they like in the ER when I ask for, especially if they have like a port or something, or if they've given a fresh IV, because it's not hasn't been contaminated with like medications yet. So like they'll flush it first, and then they'll pull the blood out, and then they'll flush it again to keep it like clean, I guess.
Yep.
But that's only if it's a fresh IV, But after that,
well, and when they have central lines or ports too, they do that as well. That's one of the best things about ports and central lines is you can pull, as an RN, you're the one that can pull blood off of those and send it off to lab instead of having to stick your patient. It's really nice. But it is recommended that about 30 milliliters of fluid flush before and after you access this to keep it clean. It's because it's about 1 ounce, and it gives you enough pressure on the inside to keep any particles of food, and when I say food, I mean like tube feeding, from gumming up within there. Oh. And I will say too, the best thing, and this goes for IVs as well, don't just go straight smooth like this. Agitate it a little bit. Give it a little bit at a time like this, because it causes agitation within the tube to really get things moving around and hopefully keep it nice and clear. Okay. When these things gum up or get blocked up, it's very difficult to clear them out. It's not like we can take like a wire brush or anything and go down there and clean things out. We used to be able to put, this is not recommended, I'm just saying we used to, since I'm being recorded. But we used to put carbonated like drinks down it, which would bubble and fizz and break it up and clear it out. But we can't do that with diabetic patients either, you know what I mean? So the best thing is just to continuously flush it and before and after you access it. Okay. Now there's different schools of thought as far as there's bolus feedings and there's continuous feedings. Continuous feedings is when they are on a pump, and I have an IV pump, but I don't have a kangaroo pump or a feeding pump that typically goes on with these things. But I can show you at least how to do a bolus feeding. So you will need the syringe barrel, okay? And you would access it this way. And I've had patients that they do this at home because they've got a peg tube. That's how they eat. And just to make sure I don't, what you would do is you would open, shake up your can of tube feedings or whatnot, Ensure or whatever it is, and you would then pour a little bit in here and let it go by itself to drain. Because gravity will let it do its thing. Okay. We don't want to overfill the stomach because we can cause it to stretch and then cause skin tear or tissue tears within the stomach. So that's why it's preferred that you let it go in by gravity. It needs to be held about 8 to 10 inches above the insertion point. So if it's a gastric tube that's here, it need to be around right here. Okay. Once it stops, that means typically the stomach is full. Don't push more into it. Just record the amount that you have been able to get in there and go on. Okay.
And at that point, you'd still have it inserted.
Correct. Yeah, I just
Yeah.
moved it over here so it didn't. This is the one that we have that has speakers and stuff in it. So
Yeah, that's a hazard.
Just a little bit. Call him Sparky.
You would be for sure.
Right. So now, I will say, removing these is a lot easier. Okay, it's basically almost the same type of setup. You do want to flush it beforehand in case there's any gastric juices or anything gelled in this. You don't want to pull that through the airway, the back of the throat, or anything like that. Okay, you take the tape off and have them take a deep breath in, and on 3, as you pull the tubing out, you want them to be breathing out. So that way, if there is anything on here, they're not and then aspirating right away. It's keeping it coming out of the respiratory system that way. So I usually have them take a nice big deep breath in right before, and on 3, 1, 2, 3, have them go as I'm pulling this out. Okay? Just like with an IV, you want to look at the tip to make sure that it is intact and that nothing has broken off. Because if there is a tip in there still, we might have to go in there and either with endoscopy or whatnot, or depending, you just have to let the doctor, the surgeon, whoever put this in know, or ordered it to be put in, that there was a piece that broke off. And they might be, okay, well, depending on the patient, oh, no big deal, they'll just pass it. Or if they've got, history of GI surgeries or whatnot, they might need to go in, endoscopy, and fish it out.
Do they breathe out their mouth or their nose?
Out their mouth as I'm pulling this out, yeah. Any questions? I will say, if you're not the nurse that has put this into the patient, you do need to know the depth of how far it went. So, and that should be recorded somewhere, which nair it was put in. So that way you can tell if it's migrated, if it's gone further in or if it's come out a little bit or anything like that. Okay.
If it comes out a little bit, do you just untape it and you have to push it back in, or what?
And then you have to reconfirm that it's in the right place, depending on how much. Yeah. These ones you can re-advance in if you have to. Those Dobhoff tubes or the post-pyloric tube that I mentioned earlier, they're actually wire guided. There's a guide wire within them. And once that's been pulled, you can't advance it anymore because it kind of crumples up on itself.
Is that like the dilation or dialysis catheter? In surgery, we use a wire to put those in laparoscopically. Yeah.
I did not know that.
Oh.
But no, a dialysis catheter typically goes into the vasculature, not for
Okay.
feeding or anything like that. They usually go in the neck now because of just the availability of vasculature up here. But then they'll probably, if it's going to be something more chronic, they'll have to go in and get what's called a fistula right here, where they graft an artery and a vein together. And that's another place you want to hear a bruit, a little whoosh, whoosh, but then you want to feel a thrill. We'll get to that when we get to CV, don't worry. But, any questions, guys?
Do we get to do that?
Yeah, I want you guys to practice a little bit. So we have this mannequin here and that one over here.